Uh, Good morning, good evening, depending on where you are. I must start this revision course by first of all thanking the organizers of this program who have invited me to take the session on the epidemiology and control of communicable diseases. I also want to appreciate all the participants who are here to listen to this revision. The learning objectives for this course is as follows. The student should be able to know the characteristics of communicable diseases, define key terms, and then also know about the importance of communicable disease and the epidemiology, and know how to describe the epidemiology of any communicable diseases. And then the levels, know the levels of control of communicable diseases. Also, expect that the postgraduate student or the resident doctor should be able to feel confident in the knowledge gained after this course, and also to appreciate the impact of communicable diseases on public health, both locally and then globally. And then they should be able to discuss the epidemiology and control of any communicable disease of interest, and to be able to institute control measures for any communicable disease with the knowledge gained from this session. So the learning outcomes, we expect that the participants should be able to appropriately discuss the principles of epidemiology as it relates to communicable diseases, demonstrate ability to use these principles to manage communicable diseases of public health importance, apply the principles of control of communicable diseases to diseases, outbreak, emergency preparedness, and response. We use this outline. We will have an introduction, formally define terms, look at dynamics of disease transmission, and then look at distribution and determinants of communicable diseases. Then actually look at what are the strategies for controlling communicable diseases. And then we will illustrate by taking one of the communicable diseases of interest as a case in point. Well, as a way of introduction, we know that disease right from the existence of man on Earth has always been an issue for man to deal with, and there have been ways to control them. The impact of these diseases right from time immemorial ranges from high morbidity and mortality to severe loss in the socioeconomic platform, loss of productive hours, man hours, losses, family, social disruption in international travels, education. Remember what happened during the recent COVID-19 and then Ebola also. These diseases have been on the increase despite all the strategies, collaboration to combat them, coupled with the breakthroughs we have had in diagnostics, therapeutics, and vaccines. That is why understanding the disease and their dynamics is critical in instituting control measures and evaluating their outcomes. But it might be good to know why we have had this increase in the communicable diseases. Well, some of them include more people are living on Earth than before, so contact is higher. People are living in close proximity to their neighbors more than ever before. Increase in global travel and trade. Activities of man on Earth, such as environmental degradation, pollution of land, water, sea, and air. If you get to some cities, a lot of planes are flying, a lot of vehicles, all these are emitting gases which impacts the environment. For example, that also happens in the waterways. Climate change, of course, is an inevitable consequence of all this environmental degradation. And this leads to a multiplicity of factors such as changes in vector habitat and behavior, mutations of these organisms. For example, we are having more and more lineages of Lassa fever being discovered, probably mutation, and the virus are changing their nature. So let us look at now what is epidemiology. As we know already, epidemiology is the study of how diseases are distributed in populations and the factors that influence or determine this distribution. Also, the definition by Lass is the study of distribution and determinants of disease and health-related events, specified populations, and the application of this to the study of control of health problems. Health-related events you will imagine like road traffic accidents, teenage pregnancy, drug addiction. All these are all not diseases per se, but they are health-related events. So we also look at the epidemiology and control of them, so the impact on health. Communicable disease is an illness due to a specific infectious agent or these toxins, which are capable of directly or indirectly being transmitted from man to man, or from animal to man, or from animal to animal, or from the environment, whether through air, water, food to man. These infectious agents are microorganisms such as bacteria, viruses, parasites, fungi, and hermits. Why do we need to study epidemiology of communicable diseases? Some of these reasons are understanding of the principle will help us to identify changes in the pattern of these infectious diseases. For example, when the disease begin to begin to occur in regions that we have not known before, the only way to know is that if we already know the epidemiology of those diseases. It also helps us to discover new infections, and eventually, if we know the epidemiology, like in Lassa fever, if you know about the disease body, the distribution among the various age groups, it help us to develop vaccines, and for other diseases to develop antibiotics for them. Now we want to look at some key terms that are important when we discuss communicable diseases. Time will fail us to enumerate all of them, but some of them I will just quickly highlight. When we say infection, we are referring to the entering and development or multiplication of an infectious agent in the body of man or animals. An infection does not always cause illness. For example, permit me because I will always be using Lassa fever as an example because that is my main area of focus in infectious disease epidemiology. In Lassa fever, most people, at least about 80% of people get infected with the virus, do not come down with the illness at the end of the day. Only about 20% of these persons who are infected will come down with Lassa fever. It's an example of one person getting infected and yet doesn't get the disease. Contamination. The presence of an infectious agent on the body surface or on clothes, beddings, toys, surgical instruments or dressings, other articles or substances including water and food. We say they are contaminated. This can be a source of infection. Infestation, on the other hand, is the lodgement, development and production of arthropods on the surface of the body or in clothing. For example, lice, mites. This term can also be used to describe the invasion of the gut, so intestine by parasitic worms such as Ascariasis. We go to host, a person or animal that affords subsistence or lodgement to an infectious agent under natural conditions. Advent of the host, obligate host, definitive primary host, intermediate host, and the transport host. I didn't mention too much about contagious disease. It's a term that's not been so used, but it refers to disease being transmitted through contact, such as scabies, trachoma, the STDs, and leprosy. A vector is an insect or living carrier that transports an infectious agent from an infected individual that is waste to a susceptible individual or its food or immediate surroundings. A reservoir is any person, animal, or arthropod, plant, soil, or substance, or a combination of these in which an infectious agent normally lives and multiplies, on which it depends primarily for survival, where it produces itself in such a manner that it can be transferred to a susceptible host. We say it is the natural habitat of the infectious agent. For example, the tetanus uh, organism stays in the soil. Also, hermits, says hermits like the hookworm, they find the soil. Zoonosis is an infection that is transmissible under natural conditions from vertebrate animals to man. An example of this is rabies, plague, Lassa fever, and the rest of them. Infectivity refers to the proportion of exposed persons who become infected, while pathogenicity is the proportion of infected persons who develop clinical disease. Virulence refers to proportion of persons with clinical disease who become severely ill or die. It is the degree of pathogenicity. When death is the only criterion of severity, it's called the case fatality rate. Let me move faster. Some of these things you can see on the slides. We'll share the slides so that you can look at them. If infectious period, the length of time a person can transmit diseases shares the infectious agent. Incubation period, this is important. The time interval between exposure to an infectious agent and the appearance of the first sign or symptom of the disease. This is very useful for tracing the source of infection and contacts. Like in Lassa fever, we use the incubation period to know the period in which we can follow up the person who is exposed. The maximum incubation period, which is 21 days for Lassa fever, is the time we use to follow up such persons. Also, incubation period is useful for identification of point source or propagated epidemics and to determine the prognosis of a disease such as tetanus or rabies. Now, if we look at another term, chain of infection, you describe the transmission of an infective agent from its reservoir through a portal of exit and is conveyed by some mode of transmission and enters through an appropriate port of entry again to infect a susceptible host. This is the dynamics of disease transmission as depicted in the diagram above. The chain of disease transmission usually involve agents such as viruses, bacteria, protozoa, fungi, or the Rickettsia organisms. A source of infection is defined as the person, animal, object, or substance from which an infectious agent passes or is disseminated to the host. The reservoir of an agent is the habitat in which an infectious agent normally lives, grows, and multiplies. This includes humans, animals, and non-living things. They may be different from the source of infection in certain areas, certain cases, I mean. It's good to know that different types of reservoir: human reservoir, animal reservoir, non-living reservoir. The human reservoir, we look at cases, people harboring the organisms. It can be a source of a reservoir, or carriers, or cases. You have a primary case, index case, And then the cases that emerge from the index cases, only cases, all these are capable of being the source of infection like during an outbreak. For carriers, we can have incubatory, convalescent, healthy. These are harboring the organism, though they may not manifest symptoms or over clinical signs, but they are capable of transmitting diseases. For animal reservoirs, examples of this include mastomys rat for Lassa fever. Then you also have reservoirs in non-living things, such as the soil and inanimate matter can also act as reservoir of infection. For example, soil may harbor agents that causes tetanus, anthrax, and coccidioidomycosis. Water of exit, I think we can look that up. That is straightforward. Usually there are two modes of transmission. They're direct, which involves immediate transfer of agent from reservoir to a susceptible host by direct contact or by droplet spread. Direct contact can also involve through kissing, skin to skin, sexual intercourse, which is gonorrhea. Hookworm can pass through the bare feet, penetrate the sole of the feet to infect humans. Droplet spread refers to spray with relatively large short-range aerosols produced by sneezing, coughing, or even talking. Transmission can also be indirect, airborne, vehicle-borne, or vector-borne. Airborne refers to particles suspended in the air, which could be dust or droplet nuclei. Vehicles inanimate intermediaries and include food, water, blood, informants could be sources of transmission. Examples of these are handkerchiefs, beddings, or surgical scalpels. Vectors also carry diseases such as malaria. Mosquitoes, the vector for malaria, for example. And then the salmonella fly, the vector for onchocerciasis. Modes of transmission, as we said, can be direct or indirect. This is typified this like this. Portal of entering B, provide access to tissues which the agent can multiply or poison can act. These are presented as shown in this slide. We can look them up later. A susceptible host is an individual that's prone to contracting disease based on certain factors. This could be genetic, that makes some people susceptible. There can be some other factors like nutrition. Persons that poor nutrition might not be able to withstand the entrance of a disease agent in the body. Age. Usually at the extremes of age, people are susceptible. There are some diseases also that have a predilection for sex, for men or women. Now, let's look at the main attributes of epidemiology. These are epidemiology's the distribution and determinants of communicable diseases. This distribution can be in terms of the location, as the place, distribution in terms of who is involved, as the person, and the ages, the sex, the racial characteristics, or time, when is it disease, or they could be seasonal, as a fever, for example, or it could be diurnal. Some occur during the day, some occur during the night. When the vectors are biting, determinants of diseases include causative agents, host factors, of course, environmental factors. All these have impact on determining whether a disease will occur or not. As public health physicians, we still understand how diseases are transmitted and being able to adequately describe them. Our main aim actually is to be able to control these diseases, which forms the basis of public health action. Most of the pandemics have occurred in recent times. We expect that the public physician should be adequately prepared for such events if they do occur in future. Control measures are preventive efforts aimed at reducing the prevalence and incidence of a disease to a level that the disease no longer constitutes a public health problem. That's by way of defining that term. Well, we have said that communicable diseases, we need to prevent them. Prevention means inhibiting the development of the disease before it occurs and taking measures that interrupt or slow the progression of the disease. Levels of disease prevention can be categorized into primary prevention, which includes general promotion, specific protection. Secondary prevention could include early diagnosis and treatment, or tertiary prevention, which is rehabilitation and limitation of disability. This I'm sure you already know. We're just going over them. But to look at them in more details, for primary prevention, we're actually talking about avoiding the emergence and establishment of the social, economic, and cultural pattern of living that are known to contribute to elevated risk of the disease. When government institute policies and legislate on certain issues, like for example, cigarette smoking, which is associated with lung cancer, people that smoke, that will be primary prevention. If the UN decide to implement strictly the international health regulation, that will form a sort of primary prevention. For example, if international flights are vector free, each time people are, if a flight goes from one, crosses the border of a country to another, that will be a form of primary prevention, because a country or a region that is, for example, mosquito free, if a flight carries a vector from a country where these flights are common, it can be introduced into this part of the world. So that malaria, for example, that was not found in a place can suddenly become a problem there. Same thing with the rats that can be carried if aircraft or ship are not properly deratterized before they take off. Whereas for primary prevention, the purpose is to prevent disease before it develops, because the risk factors are already present. So we try to control the risk factors. One way of doing that is to do health promotion or health empowerment, empower the individuals by either providing vaccination against diseases, adequate potable water supply, adequate food, feeding, adequate housing, vector control, environmental protection. All these are ways to empower the individual against diseases where the risk factors are already present. This is primary prevention. They can also do specific protection. I've mentioned already there's a immunization of susceptible host. And the chemo prophylaxis, for example, giving anti-malaria for somebody coming from one part of the world to, say, the tropics of Africa, like Nigeria, where malaria is endemic. They need to go on some chemo prophylaxis. Secondary prevention. Here the disease is already occurring. So we have to reduce the serious consequences of disease through early diagnosis and prompt treatments of cases and even carriers. This also includes having to manage contacts of the diseases and surveillance to detect other cases that may not that may be undetected at the time. Tertiary prevention refers to rehabilitation, limitation of disability, or restoration of function. This can be social rehabilitation, economic, physical. Physical, for example, for a tuberculosis patient who had a collapse of the lung or atelectasis, physiotherapy may restore function. Say to a victim of polio, physiotherapy, physical exercises may restore function. Economic rehabilitation involves people who have, for example, had chronic diseases and were recovered. They may need a sense of livelihood, income, so they need to be engaged in a particular trade so that they can function very well again. Now, it's also good to include here control community disease surveillance, which refers to continuous collection, analysis, and interpretation of health data. This aids in the early detection and response to outbreaks. Some of the outbreaks we have had is mainly because there was no adequate surveillance. If there's adequate surveillance where data are available on time and they are promptly disseminated to those who need them, we can easily pick up cases of these diseases before they become an outbreak. Surveillance usually can be active, passive, sentinel, syndromic. Another strategy for control communicable diseases will be international cooperation and collaboration. For example, there has been a lot of collaboration between WHO, CEPI. CEPI is Coalition for Epidemic Preparedness Innovation. They are a body that's involved in producing vaccines for priority diseases which WHO has identified for research and development. Nepal and Lhasa had such diseases. So international cooperation and collaboration amongst major stakeholders are a very important strategy for dealing with communicable diseases. CEPI, as I've said before, are involved in vaccine development. They're doing that for Lhasa currently. They supported them for Ebola and Crimea, Congo hemorrhagic fever. WHO is committed to issuing international guidelines like the International Health Regulation. The US CDC has also involved in outbreak response. Vaccine delivery and immunization program has been an area where UNICEF and Gavi have been involved. And the One Health framework is involved in human environment health integration. All these international organizations and bodies have a unique role in controlling communicable diseases, especially when it becomes a pandemic. Also, the diseases can also be controlled by looking at the mode of transmission, as you can see in this table. For airborne, for example, diseases that are transmitted through the air, tuberculosis, measles, can be controlled by isolating individuals by producing a quality face mask like N95. The same thing with other modes of transmission like the fecal and cholera. What is important for vector-borne like malaria and dengue, use of treated nets is important. Use of condom and health education and testing can be good for these are sexually transmitted. Same goes for blood-borne infections, which are that is B and C and HIV, safe injections and blood screening. Zoonotic diseases, such as Lassa fever, control of the animal reservoir, or vaccination of the animal reservoirs, rabies, be very helpful. Now, there are some challenges in controlling communicable diseases. One of them is the emergence of antimicrobial resistance. This can be a big challenge where, for example, we don't have alternatives antibiotic to use. It becomes a problem. That's why there must be caution. The use of antimicrobials indiscriminate use can lead to emergence of antimicrobial resistance, and that'll be a problem. This has happened a lot in TB. Emerging and re-emerging infections are occurrences that pose challenge to controlling communicable diseases. So diseases that were formerly or previously eradicated, for example, monkeypox, which was not a big problem, is suddenly becoming a threat again to humanity. In the last 2-3 years, monkeypox is re-emerging again. So these are challenges. Well, these are not unconnected with environmental factors, climate change, activities of man, increased proximity to people, person to person, different from what we used to have before. And then issues like vaccine hesitancy or outright vaccine refusal is also constituting a challenge to controlling communicable diseases. This was very prominent during the last COVID-19 outbreak. Increased global travel and commercial activities. People have to cross border either by use of flight or roads or even walking across the border. It's a challenge. Most of the borders are porous, okay, in our own setting Africa. People can easily move from, for example, Nigeria to even get to Ghana, passing through the border, sometimes without being checked. So all these are very important. These are constitute challenges. Sometimes there are intermarriages across borders. All these are challenges to disease control. Climate change, I mentioned that earlier on. So we want to highlight this discussion by looking at Lassa fever as a case in point, by looking at the epidemiology and control of Lassa fever. On this slide is the reservoir with the mastomys that we know harbors the virus, Lassa virus, and is able to transmit it to man primarily. And after transmission to man, it can then be transmitted from man to man if there's contact with the secretion or fluid from the victim who is harboring the virus. That's what is shown in this slide. Okay. Anyway, when you see the slide, you can look at the part of West Africa where it's really occurring. And that was what was shown in the map. And that was for Nigeria, but it also occurs in other countries like Sierra Leone, Nigeria, Guinea, Liberia, Togo. And we have evidence of cases now in Ghana and Cote d'Ivoire. So endemic countries typically are Nigeria, Sierra Leone, Guinea, and even Liberia. Other cases occur all year round now. However, the peak seasons during the dry season, December to April, West Africa, particularly in Nigeria. Seasonal increase during the dry season could be attributed to changes in the rodent dynamics and human activity and behavior. Distribution. All age groups and both sexes are equally affected. But groups that more at risk of latter will include those who come in contact with the rodents and the healthcare workers who have to manage cases in the hospital. People in rural areas who have to go to the farm where or live in close proximity to the dwellings of these rodents. The rodents come around in the house for food. Then that process contaminates through the urine and the feces, food that are not adequately protected. Laboratory workers who do not protect themselves are also at risk in the hospital. Hospital waste handlers, especially who do not appropriately kitted. Community school children who hunt rats for adventure for food are at risk. The infection may not be from the rats, but the process of handling the rat and actually dissecting the rat to roast it or to cook it might be the primary source of infection. This just to show the age and sex distribution of Lassa fever, both male and female are equally at risk or affected. The route of transmission is usually through eating food contaminated with feces, urine, or blood from infected rodents, handling, cleaning, and ingesting rodents, inhalation of aerosolized virus, and sweeping or cleaning of surfaces. Well, these are areas for research actually. Inhalation is not yet so as accepted as a prominent mode of transmission. Yes, human to human transmission last occurs in the healthcare settings primarily through unsafe injection, contaminated bed railings and medical equipment, needle pricks. Sexual transmission is possible if because we have found that the virus of few people have recovered from the disease can be in the semen or in vaginal fluid for up to 3 to 12 months. Research in our hospital, hospital have shown that there's also vertical transmission from mother to the unborn baby. That's why this is high mortality among women who are pregnant and fetal loss. Breast milk transmission from mother to neonates, those who are born, is been proven or demonstrated. So the risk factors for human infection in the health facility include if specimens are not properly handled, the healthcare workers exposed, if there are poor infection prevention and control practices, it can be a factor. And for those who come to the facility who are not aware, who are not taking appropriate precaution, they are so exposed. In the community, contact with the rodents, houses with doors, no nets on the doors and windows, rodents coming to the house to look for food. That way they pass urine on the container food like Gary. Poor sanitation and hygiene practices, debris around the house. All these are all sources of exposure to the virus. Lack of awareness, of course, and lack of provided education. Clinically, Lassa fever presents initially with febrile illness, which is difficult to distinguish initially from other febrile illnesses like malaria, typhoid. When the virus begins to multiply in the body, the individual may come down with fever, abdominal pain, watery diarrhea, vomiting, and if it becomes very severe, you can begin to have low blood pressure, and then the electrolyte imbalance. But sometimes these are not so obvious. You may just stop at fever and body aches. And if infection progresses, when you know the patient is going to hypertension and the confusion, coma, kidney failure, shock, and if it's not identified in time, people die. Terms that we use include suspected case is any individual present with one or more of the following: malaria, fever, headache, sore throat, coughs, nausea, vomiting, or history of contact with hospital union rodents, history of contact with a probable or confirmed case within a period of 21 days of onset of symptoms, or even a person with unexplained bleeding and hemorrhage. It may be a suspect case, especially in endemic areas. A confirmed case is a suspected case with a positive PCR, that's laboratory confirmed, or serology, IgM, IgG virus antibody demonstrated. Virus isolation, which is usually done in our setting, is also possible as a way to confirm the diagnosis. A probable case is a case that died or biologically without the collection of a specimen for lab testing. It has all the clinical criteria in case, but there's no lab confirmation. So for diagnosis, we can do PCR testing, serology, viral culturing, histochemistry. For prevention and control, primordial. For example, legislation on housing, legislation on not to protecting food, especially the one for commercial purposes, drying food on the ground, which in some communities do. Local government have had to legislate on this. This is important. Good quality housing, environmental hygiene, clear around the houses, proper netting, vaccination when it becomes available. But right now we don't have any vaccine for use for that happening. For secondary prevention for those already having disease, high index of suspicion when they come to the hospital among doctors should be the norm, especially during outbreak, and especially in endemic areas. Good health-seeking behavior of persons who are sick, people should be taught to report with facilities to detect or at least profile this disease is available. All those who are infected must be isolated and commence some treatment. For now, recovery, IV or oral is available for treatment. And then contact tracing. All those who have been exposed to the virus, to a case, in the last 21 days are regarded as contacts. And there's a protocol for managing contacts. Contacts needs to be listed as potential cases and followed up for 21 days, taking temperature every day, checking for signs of the disease. So last time we for those who develop complications like hearing loss, hearing aids, those expensive can be used. Psychosocial support is very important, especially in communities where there's stigma as issue. So, sorry about that. To conclude on this lecture or revision lecture, I would say that effective control of communicable diseases, especially those with epidemic and pandemic potential, such as COVID-19, Ebola, Marburg, all depends on our understanding of the patterns of the disease, the epidemiology, both locally and otherwise. The preventive measures we can put in place, all epidemic preparedness measures, surveillance, and timely response to diseases when they occur. And of course, global cooperation and collaboration are important in effectively controlling communicable diseases in our time. So I want to say thank you for your time. We can have a question and answer section if we still have the time.